They're those stones that are always people who did terrible things on the Sabbath.
Yes.
Dancing and such like. Get turned to stone.
Well, it's I'm not sure how much dancing we'll have this morning. Anyway, we probably better start. I'm just thinking, letting a few more people come in on the call. Yes, I think we've got a good number. So, welcome everybody. It is just 9 o'clock to the Integrated Commissioning Board Joint Committee meeting in common between the City and the local authority in Hackney. There's initially a change. I'm chairing now. Regular attendees, members will recall that obviously the chair rotates every 6 months between Randall Anderson from the City and Chris Kennedy from Hackney. And thank you, Chris, for handing on the baton. So I'll take it for the next 6 months again. One other thing just to say before we get going, Stella, in the notes and when she sent around the papers, did alert people to the fact that we do record these meetings, usually just for the minutes, but it's actually been requested that we actually keep the recording and post it on the CCG's website and the YouTube. So if anyone has any other particular concerns about that, because obviously we are a meeting in public and that obviously will help reach to the community for others to see it at a later date. So I have no hands or comments, so I take that as everyone's content with that. So moving on, I've got some apologies before the board will meet to undertake our work as the local outbreak board first for the first part of the meeting. And I've got some apologies from Councillor Bramble, who's being, I believe, Councillor Caroline Woolley is substituting, and also Councillor Anderson. Mayor Glanville is substituting there. I haven't had any other apologies. Stella, do you have anything else to say? Anyone else you need to note?
No apologies received.
Great, thank you. Right, therefore, moving on. Any declarations of interest we need to note verbally now for, in particular, as I say, the local outbreak board work, which we'll do first. No, okay, thank you. We've got a piece of time for questions from the public. Haven't received any in advance. I'm not sure if anyone wants to say anything at this stage about bringing our attention to any particular items on the agenda. Okay, I mean, as usual, I do try to take questions from the public, but we are a meeting in public, but not a public meeting. But I will always emphasise that I'll take the questions from the board members first and only go to the public as we go along if there's time. So just pause for the moment now. No, okay, so let's move on. Minutes from the last meeting. We have the minutes there. I don't propose to go through page by page. Does anyone have any comments or corrections they want to bring to our attention? No? Okay, great. But could I ask Hackney ICB to approve the minutes?
Yes.
Thank you. And City ICB to approve the minutes?
Yes.
Thank you very much.
Yep.
Right, so let's move on to our first substantial item. Richard Bull and Nina Griffiths talking about vaccinations update and the local system response to acute pressures. I wonder if, Richard, hello, thank you for joining us. We should take the, actually maybe just divide this a bit, have your presentation. We've got a good half an hour set aside for these two items, but if you want to bring our attention to the key points you want to bring in the presentation, then we'll take some questions on that one, and then I'll bring Nina in to do the same.
Yeah,
So,
I'm very happy to do that. So what do people want to know? This is very much a nationally led programme. It's really important to get this point across that there's very little scope, indeed nil scope, for local innovation or going off national direction. So we're working within very defined ways of working constraints. So we are not masters of our own destiny here. Really important to understand that. With that in mind, thinking about who's being vaccinated right now, that's fixed. That's fixed by the Joint Committee on Vaccinims. They've worked out a list of people to be vaccinated in priority order, cohorts. And nationally, we've been told to vaccinate people in cohorts 1, 2, 3, and 4 by the middle of February. But at the moment, you're only allowed to vaccinate people in cohorts 1 and 2. Those are people aged 80 or above, and people, older people in care homes and health and social care workers. So clear directions, and you're not allowed to dip into lower priority cohorts. Although this program does change, evolve, emerge constantly, and every day we're told are new deadlines, do this by X, but also potentially new flexibilities of dipping down into those lower cohorts. So, for example, some areas have already done most of their over 80s. They can't have done their housebound over 80s at the moment because there's no way of doing that. But where they've done their mobile over 80 population and their care home population, then they can dip into the 75 to 80 cohort, but only to ensure that there's no vaccine wastage. Anyway, so the local response was PCNs were told and invited by National to identify local sites. Clearly having 8, well, it wasn't justified in having 8, one site per PCN in City and Hackney, or indeed any London borough, just because the geographies don't really warrant that. I think that makes much more sense out of London, thinking about PCNs that cover towns. But in London, where you're working in a borough that's 2 miles north to south, that's clearly less of a need. So we initially identified 3 sites in City and Hackney, and they were given a priority order: Ellesdale, which was our first site, and then Lawson, which was our second site, and then John Scott, which was our third site. So covering the northwest of the borough, the southwest of the borough, and the southeastern part of the borough. Ellesdale was first to go live, partly because that is where most of the initial enthusiasm and energies lay. A lot of enthusiasm from the practice manager or ex-practice manager from Ellesdale Street, who has been working on this pretty much full time. So that's been great, and that was quick to mobilise. Just before it started vaccinating, we were told that we had to have a 15-minute observation period post-Pfizer vaccine. And then it became apparent very quickly that actually Ellesdale was not suited in the long term to be a vaccination site. It just doesn't have the room. A real blow. And its first week of vaccinating was a success, but only at huge personal effort, all the people involved. And then there were some other things that happened as well, which made life not very easy, such as having a power outage to the outside space. There's a welcome marquee there with heating and light, and the power to that failed, which was clearly not great from day one. But anyway, heroic effort got everybody through week 1. Incredibly long working days, but obviously that is not a model that can be sustained over the next 6 months. So it became apparent very quickly that we needed a plan B for Ellesdale. And fortunately, this is a great example of system working. The council were able to identify a new site for Ellesdale, and that's called Bocking Street, Bocking. And that is the council's training hub. It's a fairly large single-story training facility. Really good patient flows. We went to see it the week that Ellesdale were vaccinating, and it decided quite quickly that yeah, we would want to work with that, mobilise it, get it set up as an alternative to Ellesdale. So we've done that, and it's going to start vaccinating today. So that is great news. It looks great. I did a walk around yesterday. The mayor was there, and Councillor Kennedy, and we think it's going to work really well as a vaccination centre. So the proof will be in the pudding. The proof is in the pudding or in the eating, and we'll know later today once we start vaccinating there. Obviously, there will be teething problems, but hopefully it will work. The experience at Ellesdale showed that Lawson was not going to be suitable in the long term to be, or even in the short term, as a vaccination centre either. It's just not big enough. You need space. You need a lot of space. People understandably turn up very early for their appointments, sometimes 2 hours early, which really does not help with patient flow. And a lot of the sites we identified just were not big enough. You know, I'm really envious of other parts of the UK that have got these big roomy buildings where, you know, there's loads of parking, loads of circulation space, loads of waiting space, either for arrival or post-vaccination. We just don't have that in City and Hackney. You know, we're a dense borough and we don't have those facilities. So, you know, there are more limitations. So that took Lawson out. It became apparent that John Scott, that's where we had our hot hub, work took place to move the hot hub out of John Scott, move that to St Leonard's. That's happened. That's working really well now at St Leonard's. But it also became apparent that a load more work was needed as well to make John Scott as a viable vaccination centre, and that work is happening. So we've erected huge marquees with really good flow. And so, given once we have NHS England's approval that we can open that site, which we're expecting to have before the week of the 25th, then that will be our second vaccination site. So that will give us 2 large vaccination sites, and they should be able to do minimum 500 vaccinations a day, which is really good numbers. And that is equivalent pretty much to some of the larger mass vac sites that have been set up around the country. So if you think about Excel or IKEA Stratford, we'll be able to vaccinate similar numbers to those large vaccination sites. It does mean, of course, that we are limited to 2 large sites. But I'm afraid that is the reality. Hopefully, at some point in time, and I'm sure this is coming, but it's not coming just yet, GP practices will just be able to vaccinate people against COVID like they do with flu. But that can't happen now. National won't allow that now, but hopefully it will come. And certainly having the AZ vaccine will allow that. At the moment, it really does. It would logistically be impossible for practices to use Pfizer to vaccinate their own patients, because you need to get through all 975 doses in not much more than 3 days, really. So that is Pfizer's out in terms of mainstream primary care. But AZ has a 6-month shelf life, so that's much more amenable to delivery from a standard primary care setting.
Richard, can I just cut in for a second, because obviously we've got the Nina's section as well. There aren't lots of questions dropping in, but maybe just have another 2 or 3 minutes just to give time for some questions.
All right. I mean, I'm quite happy to leave it there and just open up, go into.
I wonder why interrupting at that point seemed like a reasonable moment.
I just talk about this all morning, really, but obviously I welcome a debate, because no doubt you've got loads of questions.
There are just some comments coming into one thing about the AZ vaccine. Just as Richard said, at the moment, it's very difficult to use that for individual houses for housebound because of the licensing and the regulations around it. Because once it comes in an 8-dose vial or a 10-dose vial, and once you've taken a dose out, at the moment you can't then move the vial again, because you've taken off the wrapping, etc. And there's a theoretical problem with infection risks putting needles through the rubber bung. But that's actually been looked at and realised that isn't really a risk at all. And the regulations are about to change, which will enable us to go to a house, give it a dose, go to another house, give another dose, go to another, and you don't waste all the rest of the vaccine, because so much of this is about not only getting the vaccine to the most vulnerable, but it's also about not wasting vaccine, because at the moment the amount that's coming into the country is limited, and we need to try and use every single dose we can. So with that little added piece, I've got a couple of hands up. I've got John first and then Sue.
Thanks, Mark, and thank you, Richard, for your update. I mean, thanks everybody for all the work they're doing on this. It's an extraordinary effort being put into, and really appreciated. One of the things we've picked up already is that there's been calls to Orthodox Jewish people asking that they have vaccinations on Friday afternoon, Friday evening, Saturdays. Concerned that that's very insensitive. That's not going down well. We know in the community already, and it plays into kind of negativity about all this as well. So we want to stop that. Is there a way that could be handled more sensitively, so that isn't a continuing issue, please?
Yeah, I have to say that's hugely disappointing, John. I'm afraid those calls were being made from practices that serve these populations, so they should know better. So yeah, we're now very aware of this, so we will be feeding this back, but very disappointing.
Thank you very much.
Sue.
Thank you. Thanks, Richard. It's a really good update, and it's really good to know how well progress has been made already. So thank you very much for all the hard work on that. I just wondered whether we have, albeit anecdotally so far, any view on how receptive people are to having the vaccine and people's attitude, and therefore how that's likely to affect take-up?
I think it's a little bit too early to say, given the numbers that we've done so far, but I understand that demand is high.
Good.
There are national figures and local figures on how that might vary by different groups, so say by ethnicity. So we understand that take-up might be lower in certain ethnic groups, thinking about Black or Afro-Caribbean. So more work will be needed to work with those communities and engage with those communities. It might be that certain groups aren't going to be the first ones to have it, but they might need more time to consider and will come forward later down the line, and there will be scope to get vaccinated later down the line. So it's something we need to be hyper aware of and monitoring, completely on top of. But it might be that other groups are just slower on uptake, but they will have uptake. They will get it later down the line.
Okay, and do we have the mechanisms in place to actually monitor so that we are able to spot those trends?
Yeah,
all
the data comes back into primary care, so our clinical effectiveness group will be doing that data linking and providing us with reports on who's had the vaccine by social demographic characteristic. Age.
Great, thank you.
So yeah, that's definitely in place.
I see other hands going up, and also there's some questions in the chat as well, so I'll bring some of those in. But also, John Geevor asks how many actually over 80-year-olds have actually received vaccination to date. What's our current data on this, Richard?
Okay, so we've done about 1,000 so far, but that includes people who have had the first wave had their second vaccine as well. Which is not always the case elsewhere in the UK. We felt it was important to honour that initial commitment, the fact that people had come forward on the basis they were going to get their second dose of the vaccine 3 weeks after their first dose. Nationally, we're told first dose only and then revaccinate at 12 weeks. However, people were going to Ellesdale. We wanted to complete that cycle and then close Ellesdale, so that's what we've done. We're doing Bocking will be doing approximately 500 older people this week, and then they'll be doing a further 2,000 older people the following week. So that will give us about 3,500. And as soon as we can start vaccinating our 1,100 housebound patients who are over 80, we will start doing that. So we're on track, I think, to certainly have all our over 80s at least offered the vaccine by the end of January.
Great, thank you. Chris Kennedy. I can't hear you, Chris. I have a bit of an IT issue. So, should we go to Randall whilst you sort your mic out? Randall Anderson, do you want to ask your question whilst Chris?
Yeah, I've got actually a couple. First, the over 80s obviously are, on average, a somewhat less mobile demographic, and these vaccination sites to them appear to be, far away, at least folks in the city. And I know there have been offers of transport, and in some instances that's worked well. I have had a report that a couple of folks were transported and got there and were told, oh, we don't have any more vaccine. So that I'm not quite sure how that happens. But do we have any realistic hope that we will get, for example, pharmacy sites opened that might be closer, or are there any other sites that we might look at opening that are closer to the city?
So national are very they control the authorization of sites. They're not allowing any new sites at the moment, and they allowed the offer went out to community pharmacy whether they wanted to come forward as sites. I tried to encourage pharmacists in the city to come forward. There wasn't any interest at that time. There are 2 community pharmacy sites in the city in Hackney that put themselves forward. They're going to start vaccinating next week, I understand. But at the moment, I'm not aware that National will allow the opening up of any new pharmacy sites or indeed any new primary care sites. It goes back to the point I made earlier. Hopefully, at some point, general practice, all of our 40 practices in the city in Hackney will just be able to vaccinate their own patients like they do for flu. So for the city, Neiman, we hope, will be able to vaccinate its own patients. But that is not allowed just yet. But we hope it's coming soon.
And then the other question is I know because it's been in the press, the letters that were sent out to people from the national booking operation for the XL confused many folks. And I just like to clarify that, or have you clarify that. If people don't want to go to the XL, they think it's more than they're up for, they will not lose their opportunity to be vaccinated. They will still hear from the GP practice. Is that correct?
That's right. Practices will continue to contact their own patients to invite them to local centres. The CCG has got no control over national comms or the letters that National send out to patients. And quite often these letters are confusing.
Yeah, I mean, at least the letter does say in it, if you don't want to go to Excel, don't worry, you'll get a contact by your GP. I mean, it does, having read it, it does say it, but obviously it says it within the text of a letter, which isn't always that clear to people who read it. But anyway, let's move back. Chris Kennedy, have you got your mic sorted out? I wonder.
I hope so.
Oh yes, we can hear you.
Thank you.
Can't see you, but I can hear you.
Okay. It was really great to visit Bocking Street yesterday, Richard. Amazing work by you and the team, and it looks really well set up to to do a good few months of vaccination at a very high level. So great work on that. Several of my colleagues and my council colleagues and myself have had inquiries from people about the definition of frontline health and social care workers. Specifically, for example, workers who work on the street doing outreach with our homeless population, who apparently don't qualify, but of course are very worried that they might be coming, are likely to be coming into contact with people who are infectious on a fairly regular basis. So I wondered if there was any more clarity coming soon about that, exactly who falls into that definition of frontline, because it's causing certainly a lot of inquiries. I think Laura Sharp had reported to Health in Hackney that she was getting about 800 emails a week, and quite a lot of them were about that definition. Thank you.
Thanks, Chris. So a lot of work's been happening over the last week about this. It's important to know now that hospitals have now all been designated as the go-to site for vaccination for health and social care workers. So the Homerton will be leading on vaccinating local health and care workforce. Siobhan Harper, who's the workforce director for, workstream director for Plan Care, she's put herself forward to help lead on sorting out the local definitions and the local priority orders, which is going to be agreed locally. And your comments about frontline homeless workers, that's already been fed up through Siobhan, so she's factoring that into the local plan.
Thank you. Thanks, Richard. We've got Helen Fentiman. Do you want to ask your question?
Yes, thank you. In a way, I want to echo some of the comments that were made by Randall. I've had numerous contacts from residents who have got a number of concerns about the programme. First of all, it's the sites, none being in the city, but I've heard what you've said about that, and it sounds like it'll be some time at least before anything further could happen around sites in the city, given the attempts that have been made so far. And I'm sorry, my Wi-Fi dipped. There are 2 sites up and running, Bocking Street, and I missed the second.
In City and Hackney, there's one site running so far. The second site will be John Scott, which is up in Rodney Downs, and we're hoping that's going to open the week of the 25th of January.
Okay, thank you. Thanks.
We're waiting for approval for that.
Okay. The next point is about the transport. Like Randall said, there've been a number of I'd say comments, but verging on complaints about the transport. I think a number of vulnerable elderly people are not keen to be sharing a minibus with other people. That, you know, it's a confined space. They're already concerned about COVID, and they have concerns about that. And secondly, one elderly patient who was wheelchair bound and needed a carer, and there was quite an argument, I think, with the driver to ensure that the carer was allowed to travel with the patient. I mean, it's you know, in a way, these are difficult and also simple things to resolve. So I think if there's nothing more we can do about the sites, can we at least ensure that the transport is a mode in which people feel safe, and where support and carers are needed, then they are allowed to travel with them. And just one final question. Is it the case that with AstraZeneca, that the 15-minute observation is also needed in the same way as Pfizer, or is it different? 15-minute observation.
Okay. Thanks for those questions. I'll answer them in reverse order. AZ, the 15-minute observation is only needed if it's thought clinically indicated. So the person doing the vaccination will work through that, decide that before the vaccination. But for the vast majority of people, we think it won't be needed. Transport. I'm not aware that any of our transport providers are using minibuses. I understand it was all private cars, so I'm surprised to hear that. There is a new option now around transport provided by local age concern, which is great, and they can provide for people who do need an escort, vulnerable single people, they can provide escort and transport to and from the vaccination centre, so that provides some additional options. But I will feedback your comments as well about how the current offer is working, with the aim to try and improve that.
Great, thank you very much. We've still got lots of questions coming in on the chat as well. So Honor, over to you.
Sorry, I think I followed the person in front of me. It's about hard to reach us, and I know that this is not in the forefront of our mind, but and I suppose it plays a bit into what Chris has just said, which is about how on earth are we going to get vaccines to street homeless people? And
also, could I just maybe, Mary McAlpine has got a comment, as Honor alludes to, about also people who, where are the, oh goodness me, basically migrants who people who have, migrants and people without documentation. So both those cohorts, if you could pick up together, Richard.
Sure. So we do have a practice for homeless patients, the greenhouse. I'm talking to ELF to provide that service about what they can do to incorporate homeless and street homeless. That would clearly have to be on an outreach basis. So those discussions have just started.
Okay, thank you. I'm going to try to have to move us on a bit because of time to Nina's presentation. Just to pick off a couple of others in the chat as well that Marion Fredericks puts in about the pharmacy in the city. If somebody did still want to come forward, that would be great, obviously in terms of access. But as you said, Richard, at the moment, National, who approve all sites, aren't approving any new sites at this moment. But of course, that situation does change with time. I mean, there may be other opportunities. It's not in our gift, if that's correct.
Pharmacy is not in CCG's gift at all. That is being dealt with entirely by NHS England. We tried to be as encouraging as we could initially, particularly with those city pharmacies, but when back in December when we were talking about this, there was no interest. There may be more interest now that community pharmacy are getting Pfizer. I can understand the potential reluctance of community pharmacy when it was only Pfizer on offer, but now it's all AZ for community pharmacy. But as I say, if National aren't allowing any new pharmacy sites to come forward, then I don't think we can just continue to lobby, but it's their call.
Brilliant, thank you. And the last comment I'll just put to Julia Gregory, who's from Local Democracy Reporter covering the city. So it's in the chat, put in a thing which I think you've really covered off, talking about is that the worries about space and making sure people don't get pushed in together, crammed in inappropriately and risk infecting one another. And of course, that's why you mentioned the large marquees, et cetera, to increase the amount of space that's available for people to, for pre and post immunisation, where they can sit and comfortably so. So I think that's why that brings back to your point about you do need space. Therefore, one of the reasons we have the 2 sites at the moment is because of those sorts of considerations about safe infection prevention control, etc. as well. And of course, because National would never have agreed 8 sites anyway, they limit the number of sites in each area, which for reasons you've also alluded to. So I think that's covered there. So I'm going to stop us now, Marion. With apologies, I can't bring you in verbally, but hopefully we covered off your question about the migrants and people without documentation. So can I turn to Nina, to the local system response to acute pressures? Again, there's a really comprehensive paper in the pack, which we've seen. Over to you to give us a few highlights. Before that, though, Richard, thank you very much for coming and presenting and taking all the questions. Welcome to stay, or appreciate you might need to go. You've got your hand up. One last point, I think.
One last point. I have to say this has been a huge system effort, and we need to recognise the contribution of the GP Confederation, London Borough of Hackney, individual practices, Hackney Volunteer Centre. There's a great big long list of people that have been involved in this and will continue to be involved in this. Huge system effort.
Brilliant, thank you. A very important last point.
I hate to think this is just to the CCG.
No, appreciate that. Thank you, Nina.
So I suppose the other side, I think Richard has updated you on the vaccine effort, but I suppose the other side of what all those partners that Richard just alluded to are also dealing with within the system is the absolute current health crisis that we are now facing in terms of the amount of pressure on our acute sites as a result of the pandemic. So I'm sure you know this, but the number of patients currently sitting in hospital beds in the Homerton and in all hospitals across North East London has far exceeded the number that we saw in the initial peak in the spring. Things are very, very tight for capacity in all of the hospital sites in North East London, particularly for critical care capacity, but also for general beds as well. And I think the amount of pressure and the work that our clinical colleagues on the wards is facing, cannot really be understated. And that is continuing. And actually, we're still working towards a peak in hospital bed demand that is likely to come. Modelling from NHS England said that would hit us on the 18th of January. It might hit a little bit later, but we're not currently expected to have hit the kind of peak in hospital bed demand. So as well as trying to deliver a mass vaccination programme, all of our health and care partners are also trying to support minimising the pressure, responding to the pandemic and also minimising the pressure on the acute site at the moment. And the slides that I've circulated is a summary of the work that many people and system partners have been involved in, really trying to respond to that current health crisis and that current pressure on hospital demand. And I think we've tried to think about the work in three areas. So we've tried to think about, one, making sure that all of our existing services are working optimally. And we have a lot of very good primary care community services and services that should offer an alternative to hospital admission. So we're really trying to make sure that they all have capacity and are working optimally, and that services like 999 and 111 are using those services where they can as an alternative to conveying someone to the hospital. The second area of work is really making sure that anyone that doesn't need to be in a hospital bed medically can be stepped down into whatever health or care service that they need post-hospital very quickly, and then they're not delayed in getting into whatever they need post-discharge. And that's been about really, really close working between social work colleagues from LBH and the city with acute colleagues, and also about making sure that we've got adequate step-down capacity in place. And through this process, LBH have worked really hard to get in place a lot more interim beds, nursing home beds, and capacity for people with COVID and for people without COVID. And that's a continued daily effort from colleagues across from our social care colleagues. And then I suppose the third area that we've had to think about is what new services or ways of working or pathways can we implement very, very rapidly to support people in the community and support people appropriately away from the hospital. And in this sphere, I suppose it's worth saying that there's been a lot of quite national kind of top-down diktats from NHS England about services that we need to have locally. Which I think to a certain extent have been helpful, but to a certain extent haven't quite fit with what we do locally. So we've had to do a little bit of adaptation to think about what we do locally. So, for example, the focus from NHS England has been very much around implementing a pulse oximeter, around thinking about how you can manage people who are have COVID and are low in oxygen levels away from the hospital setting, using acute respiratory physicians to manage people away from the hospital, where they can be managed away from the hospital. Our approach builds on that a little bit, but actually we've been thinking more about a lot of the people that we know present with COVID also present with long-term conditions. So we know that to date, 79% of the people who have been admitted, of City and Hackney residents who were admitted with COVID, had one long-term condition, and 38% had 3 or more long-term conditions. So that 38% being a subset of the 79%. So really what we're dealing with is that kind of cross pressure of both people with long-term conditions and with COVID. And we're thinking about how we can use our we've got some really good community services and really good integrated pathways to manage long-term conditions. So we've tried to think about how we can build on those pathways and those services to offer enhanced community support for people with long-term conditions, plus or minus COVID, away from the hospital effectively. And these slides summarise 5 pathway areas where we've got existing pathways or services to build on, where we've been able to think, how can we, with a little bit of enhanced support from primary care and community services, keep people presenting in those condition areas safely away from the hospital? And that should, I think, should reduce pressure on the hospital. It also, I think, lays a really good foundation for how we go forward in terms of COVID recovery as well, and taking forward also what we're doing, our kind of integrated care journey too. We have implemented a pulse oximetry service. So this was a national ask from NHS England, and it completely makes sense to do it. It is a service that offers remote monitoring of oxygen sats in the community. Patients that deteriorate can then be appropriately escalated into either primary care or secondary care, depending on what how they're presenting and what level of deterioration that is. That should help protect and fail-safe people from deterioration in the community. It could also reduce pressure on the hospital, workers' admission avoidance, if people, given that it provides monitoring in the community, and therefore people wouldn't need to be kept in hospital or admitted to hospital for monitoring. As a development from pulse oximetry, one of the areas that we're currently thinking about, and we've had a number of conversations across primary care and secondary care colleagues, is can we build on this service to think about an enhanced discharge service whereby people who are in hospital, are improving but are not yet medically stable, can be stepped down into primary care, have some additional support from primary care for a time whilst being monitored in their homes. So we're looking at how we can bring together primary and secondary care consultants to discharge people into the home a little bit earlier with a bit more support from community and primary care services. And that is a sort of active conversation that we've been having over the back end of last week and this week, and hopefully that will be in place within the next week or so. I think it's worth saying that, as I said, the level of challenge and the level of pressure has been unprecedented, but the response to thinking about how we can better support people in the community and the response from all of our kind of health and care colleagues to how we work together to respond to this current crisis has been phenomenal, particularly when these same partners are also trying to manage a mass vaccination programme alongside responding to the pandemic. So again, echoing Richard's, I think it's been a fantastic effort from many, many partners in the system, and the pressure does continue. We haven't yet hit the peak of it, but I think we've got some really good groundwork in terms of partnership working and constructive responses to how we can adequately support people in the community that should hopefully put us in a reasonably good position. I'll open that up to questions.
Thanks, Nina. And again, nasty echo. Really good paper in the pack. There's a couple of questions. One from a guest ICB. I don't know who that is actually, but just concerned about whether or not we have enough staff, enough people to provide the care that people need for patients who are discharged from hospital. And then Honor's made a comment as well about concerns about staff welfare, really, and exhaustion, and how we manage that. So one is about numbers and one's about well-being, really. Do you want to?
Yeah. So on the staff to provide care needs, so one of the things that we're doing very closely and is being tracked sort of daily by LBH is around capacity amongst our domiciliary care providers. And that's tracked on a daily basis. And actually, at the moment, our dom care providers do have capacity and are continuing to report that they have capacity. So access to home care packages has not been a kind of a stumbling block for discharge. However, it's a fragile position, as all health and care services are, just given risk of people going off sick and isolating within those groups. But at the moment, we are tracking it daily, and we do have capacity. Honor's point about staff being exhausted, I think that's a reality at the moment. There are lots of offers to staff around, there's been really good offers to staff around talking therapies and kind of support to having gone through traumatic experiences, and those are good, but just exhaustion I think exhaustion is a reality for many of our healthcare and care colleagues at the moment. And what's really difficult about this peak that we're in at the moment is, unlike the first peak, it's not expected to go down quickly. It's expected to go down much more slowly. So we will be expecting a lot from our frontline staff for quite a long time. And I think we all need to be mindful of that.
Yeah, indeed. I'm sure something we'll return to again in many fora. I've got Steph Coughlin. You've got your hand up. Steph, do you want to introduce yourself in terms of your role? Have many roles, particularly around, and also John Geeve in the chat has put his pulse oximetry offer available to all COVID patients in the community. So maybe just
that was the question I was going to pick up, Mark.
Okay.
So hi, Stephanie Coughlin, GP, and I'm the COVID lead for primary care in City and Hackney, but I'm also the NEL lead for the pulse oximetry service. And just picking up on John's question in the chat. So we have two things available in City and Hackney. The first is called the doorstop assessment service, which is a one-off set of observations, which is available to anybody, any person in City and Hackney. And then the pulse oximetry service is available to those who are over 65 or those who are under 65 with high clinical vulnerabilities. Now, there's some flexibility in that definition for the under 65s, but actually it's a more defined cohort, recognising that these are the groups of people who we can expect to are more likely to perhaps deteriorate in the community setting, and that's why those are for that cohort. But the doorstop assessment service is available to all, and the two services are provided by the same provider, which I think is absolutely key, because actually there's that crossover and interlink across the pathways.
Great. Thanks, Steph. John, Williams, can I have a question, please, without putting your hand up, just to keep me on my toes?
Thanks, Mark. I'll put my hand up in future. Just to understand about, because this information that we've just been given is really important, and it's very good for the community to understand what's happening at the hospital at the moment. And I don't think they fully are clear. There's just barriers have been put up. So what kind of clear comms that aren't too complicated are going to be sent out to the public so they understand the pressures on the hospital and how they're accessing services? Because I think the point that Nina made about this is going to take a bit longer, unfortunately, to get over is a really important point to get across to the community as well.
I think that's a very good point, John. And I imagine that in terms of just managing a health crisis, that's been the kind of key thing that people have been focusing on, and perhaps they haven't thought about public messaging being equally important. So I think that's a good reminder that we do need to send these messages to our public. So thanks, John. We'll take that away. It's a helpful reminder.
Thank you. I've got a couple more hands up. Denise D'Souza, and then Helen again. I'll bring you back. Denise,
hello, Denise D'Souza, Interim Director in Hackney. Sorry, I missed a bit of Nina's presentation. I had to take an urgent call, but I just wanted to say, you were talking about our social care providers, and I just want to say we are monitoring them on a daily basis. And I have to say, I want to say a big shout out, I think, to the work that they have done to keep the system moving and the support that they're giving their staff. I mean, they're having to cope with lots of different changes in terms of guidance and care homes about visiting. So the constant messaging that they're getting, but the ability to deliver, I think, has been fantastic. And we'll continue to support those as much as we can. I think the other thing to say too is Age UK were mentioned a little while ago, but the work that Age UK are doing, but also having conversations with Siobhan and others about how we can make sure that we're doing things at the right level. So already thinking about people that might just need a food offer, and how we can use our voluntary sector colleagues who we've had conversations with, having conversations with probably as we speak, to how they can step up so that we can again keep taking some of that pressure off the providers who really need to deliver frontline care. So just wanted to make sure we've got that shout out to those excellent providers all out there working away.
Okay, thank you, Denise. Helen, do you want to make your comment or question?
Yeah, thank you. I mean, the first thing to say is that I think the commitment and the effort from all of the staff, clinical staff, admin staff, everybody who's been involved in this has been absolutely fantastic. And I'm full of admiration for the way in which people have kept going and going and going. And we'll need to do that for quite some time to come. I don't mean I don't want my second comment to be seen to be diminishing that, but there's nothing like a crisis for changing practice very quickly. And I just wonder whether we can ensure that a lot of the changes that are being put in place now will be relevant post-pandemic and in the future, and to ensure that we capture the best of those and continue to maintain that change practice. Because in the longer run, it will make a huge difference to the way in which acute hospital services are used and the way in which primary care can support more people at home. Just seems to me to be so important that we try to hold on to that.
Yeah, thank you, Helen. I'm going to maybe think about giving the last question to John Geeve. He's got his hand up now because of time we'll have to move on shortly. John.
Sorry, it wasn't a question. It was really following on the second comment, the last comment, that the message to the public is quite a nuanced one, because absolutely tremendous efforts in the community to limit the flow of patients where that's possible into the hospital, and that's very important. But equally, we don't want people not coming forward because they think they don't want to bother the health service if they genuinely have needs, and that was a problem in the spring. And I think so it's quite a sort of a subtle message to get across, that if you are ill, you should still come forward first of all to the GP service, of course.
Yeah, absolutely. Really important to give that message. It is subtle, but it needs to be, made very clear that if you've got something else going on, you need to present. Yes. Okay. So I think we shall move on now. There's a comment in the chat about peak incidents being later in the springtime from Julia Gregory, but maybe that's best picked up in our next item, which is around the data intelligence, which we're talking about. Activity, etc. So I think yes, and Nina, you've responded to that in the chat anyway. Thank you. So thanks very much for that, everyone, for that discussion on those items. The outbreak board, we don't need to sort of formally note them, but we obviously we have noted them. Thank you. So Nina, thanks very much to you too, and Richard, welcome to stay or go as you wish. So now we'll go to data intelligence. Sandra, Chris, Diana, I'm not sure who wants to start with this. This is our regular item where you present the numbers, as it were.
Thanks, Mark. It'll be Diana to present the data.
To start intelligence.
Yeah, Diana. Well, I didn't want to make too many assumptions, but it is usually you who does that, isn't it? Yes. Thank you. Are you sharing screens and things?
I'll share my screen. Yeah.
Fine. We can only just hear you at the moment, actually.
I'll try to speak up. Is that better?
That is better. Thank you.
Hello, can you hear me?
Yeah, now you're holding the thing up.
That's
better. Thank you.
Okay. Can you see my screen? Because for some reason, I stopped seeing the main meeting. Can you see this?
Yes, I can see it.
Great, thank you.
It's not in slide deck form. It's well, it's loading again. It's not. It wasn't.
Apologies. There's usual IT hiccup when you need to present something quickly. Okay, that should work.
Yeah, that's perfect.
Okay, I'm going to try to be brief, just in the interest of time, and I'm going to outline just what happened most recently and what the numbers look like for us and what impact that had on our hospital admissions and deaths locally. So as you know, the new virus variant became quite prevalent in London starting around late November, December, and it really peaked here towards the end of December. And that actually translated into a higher number of cases in London as well as in Hackney. So according to the ONS, now around 81% of all new infections are attributed to the new variant, and that's for the data up to the week of 2nd of January, so maybe even higher proportion of cases now. In terms of how that then affected the situation in London, it was that we saw quite a sharp increase in all of the key indicators, them being incidence rate, the case rate change, so basically how fast the incidence rate was growing, the positivity rate, so or proportion of tests coming up positive. And in this chart here, I also present the testing rate. So we've got case rate, this is the top one here, then we've got case rate change for London, positivity rate, and testing rates. So currently in London, 19 out of the 33 boroughs have incidence rates over 1,000 per 100,000 population, which is very high. And in the week ending 5th of January, COVID incidence rates have been increasing in all boroughs except City of London and Richmond, where there was only a small decrease in incidence. Worryingly, there's still increase in rates among people aged 60 plus. However, the case rate change, so the rate at which that is growing, has been slowing down in the recent week. And the test positivity rate is over 20% in all but 4 London boroughs. So very serious situation in London indeed. And how that looks for Hackney. So you can see that in December, there was a really sharp increase in the number of cases. And that coincided with the new variant, so the growing prevalence of the new variant of the virus, as you've seen in the first slide. And around 60 of all Hackney and 50% of all City of London COVID-19 cases were registered in the last 4 weeks. So basically, that new spike of cases, it accounts for a large chunk of all the total cases that's been registered so far. We have seen very, very high increases in all age groups, but the highest increase was noted among the residents aged 65 plus. And again, that is very worrying because older age is associated with higher odds of being hospitalized, being taken into intensive care, and also the risk of dying from COVID-19. However, again, as I mentioned before, the rate seems to be slowing down.
Sorry, Diana, your slide hasn't moved on.
It hasn't?
You're still on slide 3 on our screen, or is that just me? Sorry.
Really? Okay.
Yeah, that's moving. I think you're moving. You're on the whatever the tartan one. I think it's been called. That doesn't very tartan.
So what do you see? So I'm on the heat map for age groups. Is that what you're seeing? An increase in incidence? Okay. Yep. Yeah. So I've discussed this slide. I'm going to move on to the next slide, which is very busy. So I'm not going to dwell too much on this slide. It is basically just to illustrate how things progressed over the last 3 months. So October, November, December, how things have changed in terms of testing rates, incidence rates, and positivity rates for Hackney wards as well as the City of London. And it's just looking, eyeballing the colors, you can see that just by intensity of color, all of the 3 indicators have really increased in the numbers. So the testing rate has shot up for most of our wards, and incidence rate as well. Positivity rate has increased in all wards except 2, or actually 3, where it was either similar to the positivity rate that we saw in October, or it was higher in October than it was in December. And these are the wards in the north of the borough: Cazenove, Stamford Hill West, and Springfield. And just general note, the EPI in those wards tend to be slightly different compared with the general Hackney picture. And the spark lines here, so that's the last column in the table, is just a visual illustration of how the rates have changed. So low, low, high, and so forth. In terms of the distribution of cases, all of the borough is really now covered. So there are hardly any areas of Hackney which don't see either household clusters or just individual cases. We have analyzed the household cluster data, and just to see whether there were any particular factors associated with that clustering. We saw that it tends to be associated with higher density of housing, so like estates or blocks of flats. So that's generally where we see higher concentration of the number of cases. But we also noticed that where you've got household clusters and those hotspots, the average number of contacts in those areas is also higher compared with the general Hackney. So there are two things. So not only it's more prevalent in areas with higher density of housing, but also there tends to be something around the profile of that population groups that they have higher number of contacts. And I think the paper was shared with this board, which provide evidence around people living in more deprived areas and working in jobs which they have no choice but to interact with more people on a daily basis. And so I think that possibly also illustrates that. So people living on council estates, for instance, working in professions where they have a lot of face-to-face interactions, and therefore the number of contacts that they have on a daily basis is higher than for people who can work from home and are working from home. We also looked at the proportion of our population which have tested positive so far, and it's very small. So only around 5% of Hackney population have ever had a positive COVID-19 test, and around 4% so actually, yeah, this is older data. Okay, I'm going to quote the older data. It's slightly higher now given more cases. So around 4.4% of Hackney and 3% of City of London residents have ever had a positive test, according to the data up to 30th of December. And it basically means that most of the population have not had a confirmed COVID-19 test. But according to estimates, the actual proportion of residents who already had COVID-19 could be anywhere between 20 and 35%, and I will present it in the next slide. So what this slide is showing is the data from the ONS infection survey applied to a local population. This chart will be available in our public dashboard, so you will be able to see it for yourself and interact with this visualization. But just quickly, so the pale green area is the estimated number of positive cases by week, and the dark green column is the actual number. So you can see that, for instance, in the last week of the available data, which is week ending 2nd of January, the number of estimated cases is about 4 times higher than the actual number of confirmed by test. And another modeling study that was produced by Edge Health, they estimated that actually it's around 35% of City and Hackney residents who could have had the virus so far, accounting for 102,000 people. If we look at the ONS estimates, that's lower. It's about 20% that they estimate that population who have had COVID so far in City and Hackney. And Nina has already discussed this, that we also saw a sharp increase in the number of bed occupancy, the patients with COVID-19 in both general and acute and critical care. And it's in the week up to 6th of January, 52% of all general and acute beds and 48% of the critical care beds were occupied by patients with COVID-19, and which was and the rise was quite sharp starting beginning of January. I'm not going to add anything more because Nina has already discussed this, and this is just a review that was done by our colleagues in the Northeast London financial strategy team, and they looked at patient flows, linking hospitalization data with case data. And they estimate that around 15% of Hackney and City of London cases were hospitalized, but this could be an overestimate because community testing did not become widely available until late April. So actually it could be lower than that. And as Nina mentioned as well, the majority of those admitted had comorbidities. And just the last bullet point is just an interesting finding that some of the areas in Hackney, so residents residing in Stamford Hill area, Hoxton and City of London residents, they do prefer to be admitted to Royal London Hospital rather than Homerton. So using Homerton statistic only doesn't quite give the full picture. The last slide is not available to you, it's just added it, but this is freely available on our public dashboard. So this is just about the number of deaths. In the last 2 weeks, we saw 27 new COVID-19 deaths. That's a lot, especially compared with the previous trend. It's nearly the number that occurred in the 7 weeks between 31st of October and 18th of December. And when we looked at the profile of the deceased, and it's quite similar to the first wave, so of the 61 deaths that were registered between 1st of October and 5th of January, 21% were among residents 60 to 69, and 66% of those were among residents age 60 plus, accounting to 83% of total deaths. So 83% of deaths were in residents age 60 plus. 51% of the deceased were from routine and manual occupations background, and just to note, about 17% we didn't know. So that's some degree of uncertainty. This could be higher, and 70% of the deceased were born outside the UK. Again, just showing a disproportionate impact of migrant on the migrant community. And this is, I think, the end of the presentation. Yes, so, and I will take questions if there are any.
Thank you, Diana. Yeah, I guess there's a comment actually David's just put in about the data that you have, which is with such a fast-moving situation. Obviously, in the last week or 2 weeks, things have moved. You know, it is as you described, but just much more, much higher. The numbers are, and then obviously we'll see the plateauing or being well, and the lag effect in terms of critical care, etc., working its way through. I don't know if there's anything you can say about anything else you want to say from that data, which any particular points which contemporizes it for sort of now. Any key points of difference you want to just describe?
I think for me was the starkest finding was firstly about the older population. So the message needs to be quite clear that there is a big risk for our older residents, and that's seen through all of the statistics from cases to admissions to deaths. And the other thing is about the risk of just getting the infection itself. So, and that's presented by the clustering of cases around the estates and blocks of flats, and just individuals' risk when they are in the jobs which are people facing, ensuring that they are following the guidelines, they are wearing the PPE, and also they get the vaccination where it comes available, and just promoting that message that the vaccination could be life-saving for them or for those that are close to them.
Grand. Okay, thanks, Diana. So I've got a couple of hands up. David, you've got your hand up.
Can I just respond to that
yes,
as well, about how contemporary the data are? We could have done something that was very slightly more up to date, but as you may have heard Diana say on many occasions before, the most recent few days of data are less reliable because of the way that the testing information and case information is updated. So the most up-to-date data are always at least 5 days out of date, in the sense that then you can't ever present today's figures because they're not reliable. And of course, we also have to have a bit of time to actually do some useful analysis. In terms of informing policy, I think they're not so out of date that they can't inform policy, particularly when we're giving a projection about where we think the peak's going to be, knowing that the peak of hospital admissions is likely to be a week or two after that. And so it means that we can plan, and we have been talking about these in other more regular internal meetings, so that people can be understanding the picture, and it's informing local policy decisions without you necessarily having to have today's numbers, because today's numbers are not necessarily the most useful numbers to work from. It's actually having the analysis that informs you about where do we need to put the focus of our attention.
Thanks, Sandra.
But it
it's
is
very
a
context.
Yeah.
Yeah, sure. David.
Thanks, Diana. I mean, I guess the key things for me at least are the critical care data needs to be up to date, because the corresponding corollary of there being limited critical care capacity in City and Hackney is that patients need to be diverted elsewhere. So that is something that we need to then manage the expectation of our population. So I think the paper showed at 50% capacity. I think it might be almost at 100% at this point in time, which we do need residents then to understand that their needs may need to be met in a different part of North East London, and increasingly potentially in different parts of London if the critical care capacity increases in that way. The second thing I think that would be helpful to have, and I recognise kind of the data flow on this isn't good, but the death rate similarly needs possibly a different set of community interventions to help people recognise some of the limitations of both the availability of mortuary space and then the lag, the corresponding lag in potential burial times, which obviously affect our Muslim and Orthodox Jewish communities in a slightly different way. So there's a set of kind of communication things that I think possibly spin out of some of the data that we then need to take as an outbreak board and an integrated commissioning board to form a set of communications and local policy interventions to prepare our communities for some of the necessary actions that come out of responding to the data, which is why the contemporary element of it, even if it was tabled on the day and even if it was rough, I think is important just for this period of time that we're in between now and the end of March. Thanks.
That's helpful and understood, although just bearing in mind that this is a public meeting, I think we have to be careful about tabling inaccurate data. But good point, David, thank you.
I've got Councillor Carol Woodley's hand up. Diana, you've got yours up again. Did you want to respond particularly to a point that just made?
Yeah, just a point of clarification. The over 50% bed occupancy is COVID patients. That's also within the slide, the proportion occupied, just generally what the load is. So the 50% is patients with COVID, not all of the patients. But also so like Sandra said, so because we need to submit this in advance, it will be older than the data that are available through NEL dashboard. And also Nina has all the up-to-date data. So we are working from up-to-date data. It's just because we need a few days. We need to submit it a few days before, so that's why it's slightly oldish.
No, that's helpful. I guess just to be clear, my point is I'm not being critical. I'm just trying to make sure that this board has a purpose in the observation of the current context and able to make, have informed conversations about what action might be required on the back of the data as presented. So take Sandra's point about it being a public meeting. I just think in the current context, we probably need it as contemporary as possible, even if it hasn't been analysed, so that we can at least get our wits about us about some of the challenges that our communities might face, because it is moving very, very quickly, as you say. And that's a fair point about the critical care capacity, but actually probably what we need to know for the purposes of this board is the overall critical care capacity, because it is that will then have an impact directly on our residents, because then we might be moving people to other parts of London for critical care support, regardless of being COVID positive or negative.
Okay, thank you. Karen Woodley, do you want to make your point?
Am I unmuted?
You are now.
Yeah, it's a question really around, I guess, the data that's difficult to capture, but our understanding around asymptomatic transmission, potential transmission amongst early years. There's obviously a lot of focus on the early years sector at the moment. A lot of very good work done around risk assessment. I think we're taking a very right and cautious approach across it in Hackney. But looking at that data around the north of the borough, thinking about multi-generational households and perhaps seeking a little bit of reassurance here about that kind of data that we can't capture about how potentially the virus is transmitted amongst those younger children who are asymptomatic, or whether we're very comfortable that that is not happening.
That's a really good question. I think we can't ever be entirely comfortable that there is no transmission among young children. Otherwise, we wouldn't close nurseries or early years settings when there were cases there, which we do from time to time. As you know, as happens from time to time, there are cases among small children. What's different about the younger children from the, say, secondary school children is that they are less likely to get seriously ill, and as far as we understand, they are less likely to spread it, but it doesn't mean that it's impossible that they spread it. But we just don't have any direct evidence that it's, say, the early years child that takes the virus into the home and then causes a household outbreak. It's actually almost impossible for us to know in any household cluster which is the index case, because they appear as a cluster as opposed to a series of cases in succession. So yeah, there'll be definitely some spread. How significant it is in the overall community outbreak is not possible to say, but it's probably relatively minor compared to older children and adults who are just much because they're symptomatic, much more likely to spread it. Even asymptomatic adults are much more likely to spread it. People who have symptoms because they tend to be coughing are therefore more likely to be expelling lots of virus over long distances, and that's why it's much easier to catch the virus from somebody who's got symptoms than from someone who hasn't. But someone who hasn't got symptoms can also spread virus, which is why we have introduced the asymptomatic testing, which we can talk about under the next item. We are collecting data about people who are being tested through that asymptomatic testing route, and we'll be able, when we have more data, to be able to say what proportion of those have tested positive.
Okay, I'm going to probably have to move us on shortly. There's a couple more questions. One, maybe for Paul, might be best if you articulate that verbally rather than me interpret it. And maybe whilst, if you can, unmute yourself. Just before that, just to put your Ed Sheridan from the Hackney Citizens put an interesting comment or question about whether the new variant is actually being proving to be more infectious in different environments and different places, or is it just doing the same as the old variant except more of it? It's more infectious everywhere. Yeah,
so it is more infectious everywhere is the short answer. So the settings where we were seeing clusters and outbreaks before, we're seeing clusters and outbreaks in now, as in workplaces, schools before they closed, care homes, households. But what we're also seeing is a lot more individual cases that don't appear to be connected to anything else. So it's just a lot more transmissible.
Okay, thank you. And Paul, are you able to verbalise your question, and then we'll move on?
Yeah, so Diane and Sandra, the message I got from the presentation was that about the low level of testing, between 3 and 4% compared to the 20 or up to 35% of residents that had COVID. And I wondered if there'd been any work in trying to identify where people looked to find out about testing initially before being signposted. And I'm wondering if that's a barrier for people picking up the option of going to testing. And of course, if we're going to see a benefit from the vaccination, we need an uplift in or testing, or at least people finding it easier to get to the testing sites. And I didn't want to put this in the conversation, but I I was signposting people this week who were asking about key workers and how to get on the testing sites, and it's not easy when you just put City and Hackney to go for a test. You don't get an immediate sort of site that comes up and say click here, follow through. So I just wondered if there's some work on there and we could do a little bit of work about making that process a lot easier, so people can just click through and have their test booked, and it's, you know, a far more efficient flow. And I know that we did ask Richard earlier last week about whether it was able for people to turn up into this at the testing site in the city, because anecdotally that's what people had done, which is probably a bit inefficient, which means that people aren't finding, you know, the how to book the site. So I just wanted to raise that as a point, really. Thanks.
So to address the first point first, I think you may have misinterpreted that slide. I think what Diana was showing you was the proportion of people who have ever had a positive test, as opposed to the proportion of people who've had a test.
Right.
And what that was telling us is that so if you assumed that everyone who'd ever had symptoms had got a test in City and Hackney, that 4% or in Hackney it was 4.4% of them, and 3.3% in the city would have ever had COVID. Although of course we know that that's an underestimate, because as she showed you from the ONS data, there are people who never got tested, particularly during the first peak because the testing wasn't available, but also subsequently either because they just didn't want to, or because they didn't think they had COVID, or they didn't have any symptoms at all. The point you made about the accessibility of testing is really important. So we've done a lot of work actually on making sure that there are plenty of opportunities for getting tested in both City and Hackney, and we've got 5 test sites, and several of them are open 7 days a week. And of course I don't keep all of this information in my head, but it's all there on our websites, so you can very easily find the information through the council websites about where these test sites are, where they are and when they're open. But for the most part, you still have to book through the national portal, which, a bit like the vaccination stuff, we don't have any control over. What we do have, and that's a quite recent development, is the opportunity to book 50 slots a day at some of the test sites. I think it's only 3 of them. So that's a couple of those, the ones in Hackney and one in the city, and so we've opened up a local booking portal for that, which is actually really straightforward. Right. And you do that through the council website. We have put out communications about this, but clearly it's not getting through to everybody, so we'll need to do some more work on that. But we do usually, almost every time we put out some sort of newsletter, we do say this is where you get tested, this is how you get tested. Because we did realise months ago that one of the major barriers to testing was that people didn't know where or how to get a test, or even, you know, why they should get a test. And that was all part of the Keep London Safe campaign, was about getting people to understand the need for testing, and then how to get a test, and to generate some trust in the whole system, that if they got tested, it was for their benefit and their families and their community's benefit, and then they could then engage with test and trace as a consequence of if they got a positive test. So there's a whole load of outdoor communications about it, as well as newsletters, literally letters that went through everybody's door, as well as regular communications and through various online and other channels that we do. But we will keep doing that, because it's clearly not getting through to everybody.
Okay.
Thank you. Can I just to say, Sandra, that I just literally went to both sites quickly just to test it, and I think what I'm sort of suggesting is that key message needs to be on the front page and it's circulating, because it's not coming up quite clearly when I tap on it. So, and if I'm not being able to pick it up, then I'm sure other people aren't. So and yes, it might have been how I interpreted the data. So Diana's, and both of you are right. But I was thinking that message there does seem to be correlation between the low level of testing and the high high rates, and I know that the data doesn't suggest that people haven't been tested, but it's difficult to understand how many people have been tested and it wasn't picked up, and then they got COVID after they'd been, so they'd had a negative test, and then maybe 2 weeks later they got COVID, and that I'm sure that's quite difficult to find. But there does seem to be some correlation, and of course testing did start late, so that's one of the issues against the data. So I'm just a bit concerned about that, really. That's all.
Yeah, no, and it's good points, well made, and going out and actually testing the system is really helpful as well to see what the actual interface is for the user. So thank you for them. I'll leave Sandra and Diana, who I notice you've put in some more comments in the chat, as has John Geeve, around critical care beds. But Councillor Woodard, is that an old hand you've got up there? Judging, yeah, okay. Fine. So we ought to move on to then just the local outbreak control plan update. Sandra, obviously we've got the paper there. We've covered an awful lot of the issues that you mentioned in the paper in our discussions. Is there anything else you want to bring to our attention? Then we can.
The key points really were that there'd been a lot of work around developing our testing, and particularly that we'd started doing local booking, which I just talked to. I spoke about in response to that last question, and also that we've also started testing at a few locations. That started very recently.
So can everyone mute, please? There's lots of rattling.
That was in response to the upsurge of cases that where we in North East London appeared to be the main focus in early December, if you remember. Of course, it's all across London and the South East now, but that mainly being driven by the much higher transmissibility or infectivity of this new variant of virus, and so we set up these asymptomatic testing pilots, which were about being able to support various settings, and in particular the community testing ones were about identifying people who didn't have symptoms. So these have been all set up all over London now, and in fact the offer has gone out to the whole country now, I think, that they can all set up this community asymptomatic testing. Because we're now in lockdown, of course, because the whole situation keeps moving. So when we started this, we were in a tier 4, I think, situation, and now we're in national lockdown. Our expectation is that people aren't going out unless they have to leave home for the essential reasons, which would include they have to leave home to go to work, or they have to leave home for caring responsibilities of volunteering. And so we're targeting our asymptomatic test offer, which is the lateral flow rapid results type tests at essential workers and carers and volunteers. But as I was saying in my earlier response to that, we don't have enough data yet to say what proportion of those are coming back with positive test results. So those were the key things that I wanted to point out from the paper. And the only other thing I wanted to say is that, which is not in the paper, but it sort of harks back to the previous board meeting and the discussion we had about the exercise we'd run in November, is that there's we are more or less at the peak of infection rates. We probably do expect to see a bit of an increase in hospital admissions associated with that, but in a week or two's time. And then there's a long-range forecast of severe cold weather towards the end of January, early February, which is exactly the scenario we'd planned for in our exercise. So we need to dust that off and see what we learned from that, so we can get in gear. As David said, this is about making policy decisions that are really going to have an impact.
Okay, thank you, Sandra. That's a really important note to end on. Thank you. So I can't see any hands up. I know that time is nearly up. The report is thorough. No, great. I can't see any hands. So I guess we should just do the full part of the outbreak board, because that's what we are, is to ask the Hackney ICB to note those the report that Sandra just talked to, and also the data report we received.
Noted.
Thank you. And City to do the same.
Yep.
Thank you very much. All right, so I think we'll finish there for the outbreak board. I propose, because we the substantial, moving on to welcoming, I should start, because I see in the chat various people have joined us in the last 5 minutes. Just to have a moment's pause before welcoming everybody and starting a shorter than usual ICB joint meeting. We have a single agenda item essentially, and that is the shortening of the meeting is really, illustrates the pressures that people are under, and I know a lot of people on this call need to get off and get on to other calls and active work. So moving swiftly on, we won't have a break. I propose that we finish as close to 11 as we can. So just going through the formalities, we've got some apologies. I'm just trying to find them again. Councillor Bramble, Councillor Renison, Councillor Caroline Woodley is staying on. Thank you very much, Caroline. Any other apologies, Stella?
No other apologies.
Okay, thank you. We've got the declarations of interest there. Has anyone else got anything else to say in regard to the item we're going to be asked to agree and approve today? I have noticed that my update about becoming a non-executive director at the Homerton isn't on there, so apologies for that. Just to note that should be there too. Okay. I think, yes, can I ask ICB City and ICB Hackney to note the declaration of interest?
Noted.
Thank you.
Yeah.
Okay. Questions from the public? We haven't had any in advance. The usual, I will attempt to bring in public as much as I can, time permitting, but always I will turn to the members of the group first in comments. Moving on to the minutes of the previous meeting. Just quickly, does anyone have any comments about the minutes? Any adjustment changes? Nope, can't see any hands or chat. So are we happy to the Hackney ICB to approve them?
Approved.
And City ICB to approve them?
Approved, yeah.
Thanks. Thank you very much. Just the action log. 2 actions closed. The first action is still pending. It's clearly sitting with Jonathan and David, but it is something that obviously has been somewhat displaced in terms of bringing it here by the necessities of responding to the pandemic. I don't know, David, do you have any just brief comment about that, when it might be coming to the board? This is
well, we've got draft terms of reference, which will be doing the rounds with colleagues. We've got nominations now from the primary care networks, so we're a bit clearer about who is going to be representing the primary care networks on the ICPB. And the Neighbourhood Health and Care Board is due to be meeting ideally at the end of this month, at the latest early February, to review the financial position and get orientated to the new world of planning and delivery that they're going to need to be involved in. So we're aiming for a workshop in March, but I suspect much of our discussion may have to happen online, and we'll try and bring as much as we can to the February meeting.
okay, thanks, David. So City ICB, can you note the action log?
Yes.
Hackney ICB, note as well, please.
Noted.
Yes. Thank you very much. So let's move on to our substantial single item, looking to Nina Griffith, Mark and Dr. Stephanie. Stephanie Coughlin is with us again on the Neighbourhoods programme now, the business case and request for programme resource, which we're actually going to be asked to approve today. And obviously we had a good look at this towards the end of last year. So it would be great in terms of your presentation of the highlights to really pick up on how you've responded to some of the feedback you've had since you were last here. I know not only from ourselves, but all the other groups that you've been to as well, which you note in your cover sheet. So I'm not sure which of the three of you will be kicking off, but I'll hand over to you now.
Hiya, Mark. Hi, everyone. I will kick off and then Mark will come in with a bit more detail. Steph is here as well, so we're all three of us here to answer questions. So thank you for having us this morning. As you said, Mark, this is a request from the ICB for the programme resources needed to continue the neighbourhoods programme into the year 21-22. So we're asking for a similar level of funding to prior years to continue to progress the programme and continue to deliver against the kind of neighbourhood strategic framework and delivery plan that we've shared with you previously. Included in your pack, or what's included in your pack, is 3 documents. 1, a cover sheet. 2, some summary slides that summarises what we're planning to do next year with the resources, and then a much more detailed, full detailed document that describes in a lot more detail what resources we're asking for and what in more detail we will deliver with those resources. As Mark said, we did come to this group in this board in December, and we presented a earlier iteration of these documents. So what you're seeing is, to a certain extent, repetition from what you saw in December, but that's intentional. But also what we've included in there is updated and changes based on the feedback that we got from this group in December. And we've also included a summary of the changes that we've made to the programme plan for next year as a result of feedback from this board. So that was really helpful, and thank you for partners for your input into this.
Nina, as you draw breath, let you have a moment. I've just been reminded by Stella, I should have reminded everyone as we started the news, this part of the meeting, that we are being recorded for people who've just joined the ICB itself, that we normally record for minutes, but actually now we're recording and going to be posting on the YouTube via the CCG website, just to make sure everyone's fully sighted on that. So apologies for that, and sorry to interrupt. Over to you again.
No problem. That's not a problem. Thanks, Stella, for the reminding. I was aware it was a public meeting. I guess I just wanted to say the plans are, as I said, continuing to progress the neighbourhoods programme into next year, and really continuing to embed and deliver our kind of vision for integrated care, joined up working around our populations of 30 to 50,000, which has been a core part of our strategic aim in City and Hackney for a number of years now. There's been significant progress over the last 2 years of the programme, but we have further work to do, as described in this case, to really embed and develop those ways of working through next year. The case has been very much, what's in front of you has been very much bottom-up work. So we've worked with all of the kind of health and care partners and local authority partners in City and Hackney on the programme, and to develop the specific aims for next year. This specific document has also been through the SOCG, it's been through the BCF governance group, it's been to the CCG Finance and Performance Committee, and also to the CCG governing body in advance of coming to this group. And we've also appended some of the feedback that we got from those groups at the back of the slides. I think it's worth saying that the programme has had to adapt to a certain extent this year in relation to COVID. And while that hasn't changed the direction of the programme, we have had to prioritise certain elements of the programme over other elements. So we've really had to focus on some of our integrated care models and MDT working within each neighbourhood. And we've been able to escalate some of those initiatives this year, given their importance in relation to our COVID response. And I think that's been real testament to the programme that actually the experience of COVID has really evidenced the need for integrated working within neighbourhoods, and how important that is to support our local communities and to deliver strong community-based services within City and Hackney. So, as I said, this is an ask from ICB to approve the ongoing resourcing of the programme for a future year. I will pause there and Mark will give a little bit more detail on the detail of the asks and deliverables for next year.
Great, thanks Nina. I will, as Nina said, I'm just going to very briefly pick up on 4 things, and I'm going to particularly draw out, if it's okay, some of the feedback that we've had and some of the changes that have been made as a result, because I'm conscious that some of these slides you would have seen previously. So I guess just to highlight, so just by way of setting context, 2 things that I wanted to highlight in context setting. One is we had some really helpful feedback from a number of the groups around the emphasis upon relationships, both relationships between practitioners and different professionals, but also relationships with patients and with residents as well. So very much you'll see we've woven through an emphasis on that within the documents, and highlighting that really at its heart, neighbourhoods is about culture, it's about ways of working, both with residents but also with professionals, between professionals as well. The second element we've highlighted in the documents is putting this in the context of the broader services that are being delivered across City and Hackney. So in your packs, you'll see a slide that highlights how this programme, alongside other programmes, is helping redesign services across City and Hackney, and particularly community-based services. So community health services, mental health, primary care, community navigation, voluntary sector, as well as council services. And I think that's important, bearing in mind that this, what we're asking for is a part of helping transform those wider services and bring together community services at that neighbourhood, at that 30 to 50,000 population level as we go forward. And very much this programme is about working closely and in collaboration with primary care colleagues and primary care networks. This is about us working collectively together, and very much a core part of this is supporting all of our ambitions, support those populations at a local level. You'll see within the slides that we have outlined what progress has been made this year, and we talked a lot about that previously at this session last month, so I'm not going to go too much over that. As Nina said, we have prioritised a number of aspects of the programme this year in relation to COVID, both in terms of that community engagement, which some of the voluntary sector work has been leading, as well as Nina's mentioned the MDT working that's been progressed to support particularly vulnerable residents over the last few months, and that gives us a really good platform to build on as we go into next year. You'll see within the slides, looking at plans for next year, that is based around the 6 priorities. They haven't changed significantly. I think the feedback that we had from the different groups is that broadly those priorities look like the right things that we should be focusing on. And as a reminder, priorities 1, 2 and 3 is about focusing on those cohorts of the population, bringing teams together around those cohorts, and supporting that with that integrated working across those teams. So priority 1, 2 and 3 is more of that operational sort of working on the ground. Priorities 4, 5 and 6, you'll recall, is much more about the infrastructure and the partnership structures and partnership working at that neighbourhood local level as we move forward. And that draws on some of the partnership working that we mentioned before in Welsh Street Common, as well as specific work that I know Shoreditch Park and the City are keen to be progressing, and then thinking about how do we take that across all areas as we go forward. The last thing that I wanted to highlight is around, obviously there's where you won't have seen before is the breakdown around the costs, so that's now included. For those of you who were at ICB last month, you won't have seen that previously, and that gives a breakdown for each of the individual services. And very much this is a system, as Nina said, very much a bottom up and a system proposal that's coming to you today. And we've also cut that that funding ask around the 6 priorities so that you can see how that funding will be used to progress on those 6 priorities, which hopefully is helpful for you. The last area that I wanted to mention is around the opportunity costs and also future sustainability. So we had a couple of questions around there's benefits of neighbourhood working, but what are the opportunity costs? What are those things that we need to be aware of if we are taking a 30 to 50,000 population approach? And you'll see within the slides that we've highlighted those 4 opportunity costs and some of the areas that we will need to do across the system in response to those areas. The other elements of the presentation highlight sustainability. So again, ICB members won't have seen that previously. That looks at each of the individual providers that are taking work forward through neighbourhoods and looks at what the routes to sustainability is for those projects. And they're based around 3 areas. One, those projects where sustainability routes are clear. Number 2, where during the course of next year, we will need to agree what the routes of sustainability are. And then number 3, where there's projects that are perhaps at an earlier stage, which will need further work to define that as we go forward. And then finally, I just wanted to briefly mention something around evaluation. So we had a number of questions around evaluation. 2 things really to mention on the evaluation. One is that the projects, the individual projects that we are funding have been asked to carry out and put an evaluation arrangement in place. So where, for example, we've got adult community nursing or adult social care that are redesigning their services around the neighbourhood's footprint, they are building in some way of measuring and looking at how do we evaluate the impact of some of those individual project-based changes. But we also do, over the next 2 to 3 months, we have Cordis Bright who are going to be coming in to build on the 6 domains that we developed previously to put in place an evaluation framework. So both a theory of change for neighbourhoods programme as a whole, as well as working with us on the individual outcome measures for the neighbourhoods programme as a whole. So work that's already underway, and as I said, obviously that's work that we'll be taking forward with Cordis Bright as we go forward. And there's also some aspects in there around evaluation, taking into account some of the national evaluations that have taken place around integrated care models as well. So that sort of gives, I guess, a summary. I didn't want to sort of replicate what we talked about before because you've seen that, but hopefully that gives you an indication around the plans for next year. And I think our intention was opens up to questions, but I'll hand back to Nina and you, Mark.
Great, thank you, Mark. And that was really clear and helpful summary. I don't know if Steph, you were going to come in at this point, or just pick up on questions before I go to the.
And I'm just here to pick up on questions, Mark.
Very good. Okay, David, you've got your hand up.
Just to round off the exposition by the team, I mean, this is our major strategic delivery plank and anchor of work. So I think if we nail this right and we get around it properly and with enthusiasm, we will really make on City and Hackney and develop our own model of Wigan here locally. So that's all I wanted to say, and well done to the team.
Yeah, thank you, David. So a little flurry of hands have gone up, which is great. So I'll actually go to Heren because in your capacity as a PCN lead GP. Heren, do you want to make a comment? Just introduce yourself quickly, and then I'll go to the members.
Yes, Mark, thank you for that. Mark, I got 2 comments on your document. I had a good read at it. And overall issue is that so there's a lot of emphasis on community services and use of digital platforms and so on. But there are issues around digital divide. So unless we address that, that's going to be a big issue in general practice for us to manage. So I think the document has to spell that out. And second thing is, you mentioned that a lot of changes this year made due to COVID. But I think what there is something lacking is years to come. There's a lot of issue around long COVID syndrome, and we have to support those big chunk of people in the community. So I think you should mention somewhere as well.
Okay, thank you. And do you want to come back on that at the moment?
Yeah, I'm happy to mention on that. So yes, absolutely, digital divide, and in fact, Heren, some of the work that Hackney CBS have been doing through the neighbourhood conversations across all of the 8 neighbourhoods has been highlighting elements around the digital divide, and I know that's informed some of the council's response and some of the work that voluntary sector are doing. So yes, really good point, and definitely something that across the system as a whole we'll need to be working on, and that will obviously need to include voluntary organisations as well as the council as well. And in terms of long COVID, yes, absolutely. There is separate work outside of sort of this specific neighbourhoods programme around long COVID, but certainly as we evolve some of the MDT working, there's an opportunity for us to be thinking about how do we provide that integrated support for some of those members of the community as we go forward. And we've already got some of the arrangements in place, as you know, Heren, through the MDT working over the last few months. There's a good platform there for us to build on. But yes, that definitely needs to be an area of focus as we move forward. So very helpful points. Thank you.
Thank you. So Caroline Woodley, and then we've got Randall Anderson, Helen Frenchman and Chris Kennedy. I might gather 1 or 2 of the questions together, but let's see how we go. Caroline.
Okay, thank you for such a comprehensive paper, and obviously really support the plan, and always nice to hear about the theory of change. Around Start Well, can I ask about the education and health virtual teams to be built around the child's school? I understand concerns that have risen through COVID. I understand this builds on the configuration of WAMs and is expected to also include children with SEND, complex needs and long-term conditions. Slightly nervous about that phrasing, that it's expected to include children of SEND. I'd like to see it will include children, just have a bit of assurance that we are going to gain greater understanding, I guess, of the impact on health and well-being of COVID on children and young people with SEND. I'm hearing anecdotal accounts of kind of behaviours, I guess, we expected, anxiety, obviously trauma-aware, bereavement concern, but I'm hearing anecdotally from parents around eating disorders, perhaps some things like OCD, these kind of control, I guess, behaviours. I wonder if we have a plan for capturing those sort of behaviours so that we understand what's emerging and whether we can write into the plan ways of mitigating. I'm wondering if we're looking at a plan for similar networks of support for SEND post-19, because I know that you put that very firmly within the schools period of 16 to 19. And forgive me, I'd also like you to elaborate on what you mean by the think family approach. Sorry, Chair, that was quite a lot of questions in one.
Quite a lot, but I'll let them have a think whilst they have to hear another question. So, Randall, do you want to give yours? Because we can pair you up, and then I'll get Helen and Chris to ask their questions together. Sure, so, Randall, do you ask yours?
Yeah, I'm happy to, but it probably doesn't pair up terribly well with the questions, the very important questions that were just asked. But I must say, there's a lot of really good work here. I'm really pleased, especially pleased about the real progress that's been on MDTs. My question is around, and this will be no great surprise, priority 4. And basically, there's a lot of work here, or planned work, around sort of figuring out how to hear from people about their priorities. But what's less clear is sort of who they're actually talking to, if you will. You know, once you kind of have done a bunch of work figuring out the priorities, how does that actually go somewhere? And that's probably around my old hobby horse of a bit of mini governance around this. Thanks.
Okay, so I don't mind which order you picked them up in. Over to the team.
That's helpful, thank you. I don't know if Nina wants to jump in a second, but if I take Councillor Woodley's points to start with, really helpful. So just very briefly, think family approach to start with. So one of the things that we've been really conscious of is through that integrated working, the MDT working that's happened over the course of the last few months at that sort of neighbourhood 30 to 50,000 level, is that often many of the adults that are being discussed about, actually they're part of a family, and sometimes we separate and we have discussions and we work with adults and we work with children, but actually we want to be adopting much more of that family-based approach across the programme as a whole as we go forward. So it's trying to move away from just the focus around children's and just the focus around adults to how do we support that family approach as a whole. So that's a key part of that work. The points around SEND, so that was probably a phrasing point. Yes, absolutely, it will do. That's a key part of the work going forward. And in fact, the children and families work is actually building on. There's already fantastic and really good integrated working for children, young people, and families. So it's very much going to be building on that work that's already underway across City and Hackney. And as you would have seen through the proposals, it's the two aspects. One looking at 0 to 5s, and then the other, as you would have seen, focusing around 6 to 19s. That's probably at a slightly earlier stage than some of the other project work in the neighbourhoods programme, but certainly an aspect that we want to give more focus to on neighbourhoods as we move forward. And as I said, focusing on that family approach overall. In terms of the point that was raised around who are residents talking to, that's a key. Nina might want to come on this afterwards, but that is the partnership approach that we described is a key area that we need to focus on over the next few months. This year, for COVID reasons, has particularly focused around moving some of the operational aspects forward, but it has meant that probably we've focused less on the sort of structures and the partnership elements. So that is definitely an element that we're going to be working on, and I know that City colleagues are taking some of that work forward and liaising with Shoreditch Park and the City on some of those aspects. So yes, definitely that's a key aspect as we go forward. Nina, I don't know if you want to pick up on any of those aspects at all.
Yeah, and I mean on the partnerships and the kind of governance approach, I think as Mark said, that's something that wasn't prioritised this year because we focused on service delivery in response to COVID. We have got within the neighbourhoods, within the Wells Street Common neighbourhood, we've got the Wells Street Common Partnership, which has been a really impressive partnership of voluntary and statutory sector partners and bringing in the resident voice. And that's the model that we want to really look at and see how we can emphasise that and sort of build on that for the other neighbourhoods. I think Shoreditch Park and City needs a different approach. We know that the partners involved in Shoreditch Park and City neighbourhood are slightly different in terms of, obviously, the City of London provide the local authority and social care services. There's also the strong interface with Tower Hamlets, given the way that patients use services and flow across that City Tower Hamlets boundary. And there's already been work started to pull together specific that partnership of Tower Hamlets, City residents, and obviously the PCN partners in Shoreditch Park and City. There's also been a specific piece of work that Jenny Darkworth put her hand up, but that Jenny's initiated with City colleagues around the resident, gaining a view of the resident voice within the Shoreditch Park and City neighbourhood. So specifically making sure that the resident voice is adequately represented and does represent the population across Shoreditch Park and City, acknowledging that sits across both City and Hackney boundaries. So I think the approach has started within the Shoreditch Park and City neighbourhood, but will be slightly bespoke for that neighbourhood, given the different suite of partners involved in that neighbourhood. Jenny Darkwa, who's the clinical director for that PCN, has got her hand up. I don't know if it's worth bringing her in now if she was going to comment on that specifically.
Yeah, thanks, Nina. Yeah, it was really just to say, sorry, I'm Jenny Darkwa, I'm clinical director for Shoreditch Park and City. Hi, everyone. Yeah, it was really just to kind of corroborate what Nina's been kind of talking about. So in Shoreditch Park and City, we are absolutely looking for that resident's voice. So we've actually got a whole pilot project, which is based around kind of leafleting at least 20,000 patients within our catchment, including the City and the Hackney. We've worked very closely with Health Watch and other voluntary organisations to make sure that we can hear what it is that the residents want, and then actually kind of start to design our services around that. And so, yeah, so it's a piece of work that's in progress and very much working in collaboration with Mark and Nina in the neighbourhood to kind of look at that 30 to 50,000 patient population so that it's bespoke, but we also want to hear what patients want, what clients want, what the residents want. So yeah, that was all I needed to say.
Okay, thank you. All right, I'm going to turn to Helen Fentiman and then also Chris to aggregate their questions. Helen. And then David,
Yeah.
I'm going to bring you in at the end. Is that all right? Or did you? Yeah. Okay. So Helen.
Yeah, I'm looking particularly at the slides at 5B about evaluation. Yes, there have been lots of studies, and you mentioned lots of studies that have been used in the past to evaluate the impact of neighbourhoods. And I do appreciate the system change actually is quite hard to measure. But my assumption is that in the original design of the neighbourhood framework, you had some idea of the impact that you wanted to have on support and care and outcomes. So the question really is, in a system change where it's easy to get to softer measures, how do you think you're going to get to the harder measures of specific outcomes for patients and residents? Difficult, I know, but it's really important when there's quite significant investments being made.
Yeah. Okay. Thank you, Helen. And Chris.
Thank you, Nina and Mark. Great work. Really enjoyed reading it. Many of us have been responding to the Integrated Care System NHS transformation document over the course of the last couple of weeks, and lots of us expressing a worry that the tendency of that is to pull the system up, while the consultation documents speak very well about the importance of, at the PCN level, delivering really good healthcare and health outcomes, and looking at 4A and 4B and the resource that is there. Lots of it is assuming it's fixed term resource. It delivers transformation within the system itself and the internal systems of individual providers. But I feel to really deliver at the neighbourhood level, at least some small part of the system needs to say, and here's some resource that makes sure within the system as a whole, we keep looking specifically at the PCN and neighbourhood level. I'm worried that everything is just fixed term, and then it finishes and assumes transformation is done. But I think it's something we need to keep on an eye on all the time, if you see what I mean. Thank you.
Thanks, Chris. So back to Nina, Mark.
Yeah, that's helpful. Thank you. I was just looking at Nina to see whether she was coming in or not. That's fine. I can pick up on those questions. So really good point around the harder measures. We described sort of 6 domains within the overall framework for neighbourhoods. Some of those, you're right, are going to be softer measures based on what we're hearing from practitioners, but also based on what we're hearing from professionals as well. But very much the work will need to be looking at harder measures, and particularly I'm going to take a practical example, or 2 practical examples. One around the MDT working. So yes, MDT working at that neighbourhood and integrate the local level. Yes, it should hopefully be about improving relationships between practitioners. Yes, it should be focusing around person-centred care and ensuring that residents only have to tell their story once. But we also need to be looking at what are the opportunities there for early intervention, which is reducing a need for perhaps more crisis risk responses. So how can we support people at a much earlier stage? And that will need to include specific measures around that. So as part of that work, we're doing that. And equally, obviously, some of the work is about redesigning services so they're working at that neighbourhood footprint going forward. And I certainly know for adult social care, we've done quite a lot around, and this adult social care within Hackney, they've done quite a lot around their measurement framework around how they're going to look at what the impact of that is. And that does include hard measures as well as some of those softer measures as well. So it is really tricky. And I think, the evidence has shown that it is really tricky for areas around the country, but we need to be doing that, and hopefully we'll be drawing on some of the insight that we get from Cordis Bright as well going forward. And then Councillor Kennedy's points around the sustainability and the longer term sort of aspects. I mean, Nina might want to jump in on this bit, but yes, totally agree. And when obviously we did get asked what the sustainability routes are for some of the projects, but as we've described, Neighbourhoods is a long-term programme. Yes, some of those new care models may be implemented, but we shouldn't. We will need to remember that actually some of that integrated working is going to take some time, because it's about going back to relationships and culture change. That doesn't happen overnight. That does take time to implement and embed across different organisations.
Yeah, and of course we will be hearing how things are going, you know, as it goes on, in a kind of action learning way. So we'll be keeping you, we'll keep asking those questions. I'm aware of the time. Nina, did you want to come in quickly? I'm going to, I've got David's hand up and I'm going to bring him in at the end. And Shirley has her hand up, and I'm just going to say, Shirley, if you want a quick question, that's great. But time is, as ever, galloping on. Nina, do you want to make another comment on those last couple of questions?
I was just going to respond to Chris's point. I think you're absolutely right. We need to be alive to the risk of things being pulled up. I think in terms of sustainability of the programme, there's two elements to it. There's one, the kind of future funding models for new models of care. And most of the services that we're describing and transforming within neighbourhoods have recurrent funding models, recurrent funding in place, but need to shift how they're delivered. So there should be a route to sustainability for kind of services. But I suppose the other side of it is what infrastructure we put in place at a neighbourhood level is needed to be put in place at a neighbourhood level to sustain kind of the neighbourhood approach and responding to what residents want and need at a neighbourhood level. That's the bit I think we need to, that's the bit I think you were talking to. And you're right, that's the bit where there's not necessarily a current recurrent kind of funding in place for. But I think that's what we have to define this year and think about what the need is this year and come up with a case for putting sort of that funding in place this year. What we can't do though is we do need to be careful that we don't create little mini empires around each neighbourhood and create silos around each neighbourhood. Because you know lots of things still need to be done at a different scale. But I hear you. We do need to put sufficient kind of infrastructure around the neighbourhood so they can respond to local needs, hear local voices and respond to local needs at that level.
All right, thanks, Nina. Jenny, I assume that's an old previous legacy hand, and Chris similarly. So we're going to have to wrap up here. The last couple of comments, a quick comment from Shirley, then David, because I'm aware that we need to make a decision on this, and I'm also aware that people will need to get off the call because they've got other commitments they've got to get onto. So Shirley, over to you for your comment. Shirley McGrath.
Thank you very much, Chair. And very quickly, and sorry about this, but I can't remember whether in the business case there is a provision for a contingency fund, but I want to ask whether there or generally in the system there is going to be room to meet what is clearly going to be increasing demand for some at least mental health support from frontline staff. I mean, I don't know how some of those people are just managing to get into work every day, and what they're doing is absolutely phenomenal. But clearly there is ongoing burnout. There's going to be more burnout, increasing sickness rates, and so on. And is there any provision to meet that at any point?
Thank you, Shirley. We've covered some of this earlier in the meeting, but actually clear planning is a challenge. Nina.
Shirley, I think this area is being addressed by the system, and there is an offer and room for psychological support. I think you're absolutely right. Burnout and exhaustion and post-traumatic stress is a reality for many of our health and care staff at the moment, Shirley. That is being addressed. So there are therapies, talking therapies and services that have been offered to our health and care staff that have come out of the Psychological Therapies Alliance in City and Hackney. So that is available, and I think will continue to be available. It's not within this neighbourhood's case, but it is there within our kind of wider system plans. But it's a really important point. Totally concur with that.
Thank you very much.
Thank you, Shirley. All right, David, you had your hand up. It's gone down again. Was that deliberate?
No, I think it's just a bit of an exciting opportunity for us now as we agree this case, because it's been a strategic programme in development for a while, and I guess we need to, whilst we ask what the neighbourhoods can do for us, we also need to ask what we can do for the neighbourhoods, and that's a bit of a kind of a shift in emphasis in policy terms, because it is the programme through which we as a partnership now need to gather around to improve people's lives. That's the sum total of it. So it's really exciting. Well done to getting to this point, and it has my fullest, and I know the CCG governing body's fullest support.
Thank you, David. And it's also gratifying also in the chat, being able to continue these conversations outside the room, offline. Mark and Helen, I know you've already exchanged thoughts, and you'll continue to pick that up, and we'll continue to receive regular reports, because it is such an important piece of work. And I must say, I think hugely impressive. So thank you very much for not just coming today, but for everything that sits behind it. So moving on, we are the City of London and Hackney Integrated Commissioning Board are asked to make a decision on the request for programme resource to neighbourhoods in 2021 to 2022. The request is for £1,112,158 from the Better Care Fund, pending that final CCG allocation of funding to be confirmed for 21-22. So I just want to note that both Jake and John from CVS and Healthwatch Hackney respectively put in potential conflicts in the chat. They're not actually formal members of the committee that are going to make this decision. So actually asking the actual members of the City ICB, are they happy to agree to this?
Yes.
Indeed.
Yes.
Thank you very much. And Hackney ICB, are we?
Yes.
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 Great. Super. Thank you very much. All right. Well, there we go. Thank you, everyone. So I appreciate the times moving on. Any other business? Haven't been notified of any in advance. Okay. So then just for a moment, we always try and have a moment to pause in all the hurly-burly of life for any reflections on what we've done today and the work we've done. I see, Shirley, your hand is still up. I guess that's a legacy hand. Randall, you've just popped your hand up.
Yeah, I suppose this isn't exactly a reflection, but I do think that for the past several meetings, we've not really paid much attention to the risk register, and I do appreciate that it's a very rapidly evolving situation, but I think that there are clearly a number of risks, and some of them are really quite significant. I think that we should consider, perhaps in our next meeting, having a serious review of the risk rather than just having it as an agenda item.
Thank you, Randall. Okay. Anyone else want to make any reflections on the work and how we've got on today?
Yes. Can I, Mark, very quickly, a reflection, which is to, if this is not too public a forum to do it, congratulate those GPs in Hackney who have decided to ignore the nonsense of government in refusing a second jab to people who had already a date for their second jab after the first one in terms of delivering the vaccine. There are other GPs in other parts of the country and places that are doing that, but I mean, I think it was an appalling decision on the part of the government, wrong on moral, economic and health grounds. And
Shirley, I'm going to
well done to people who have done it.
We need to we were just reflecting on the work of the meeting today. I know that was highly contentious for those who had appointments already booked in, and as you say, many of them have proceeded to have their second dose last week. But from now on, it's clear that getting everybody to have a single dose is the clear public health messaging, rather than to give everyone a large chunk of protection, and protection sufficient to keep them out of hospital, and protection sufficient to prevent death, which is the ultimate horror of this disease. And that policy of moving to a second injection for 12 weeks is currently what nationally are dictating we do, and there is good evidence for that, and certainly in public health grounds. It is constantly under review, and we will continue to discuss that in other places. But I know that obviously some who already had their appointment, rather than trying to rebook it and reorganise it, was deemed virtually impossible to do in the short time frame. So those people proceeded through to have that. And we obviously didn't want to risk wasting vaccines, so that's always paramount in our thinking as well. Haren, and then I think we have Honor, and then I think we should stop.
Yes, it was nice to be back after 2-3 years to ICB. It was a focused agenda. There was a good scope of debate and well chaired. Thanks, Mark.
Thank you, Haren. Honor.
I suppose it's to echo what Haren has just said. I think we've sat through the local outbreak board where we're looking at death and despair. And in this part of the meeting, we've looked at building something as if COVID isn't really going on at all. And I think that is such flexibility in the part of our collective workforce that I just think we have to pay tribute to people, that they can imagine a post-COVID world and they're planning and building it. And I think it's hugely impressive, hugely impressive.
Thank you, Honor. That's a very supportive note to end on. An end we must, I think. So thank you for everyone's time. We'll see you next, I think it's on the 11th of February, it is here, for our next ICB and Outbreak Board meeting. But I'm sure we'll see each other, many of us, between then and now. But in the meantime, stay safe, and thank you very much. Cheerio.
Thanks, everyone. Thanks, Mark.
Bye.
Thank you. Thank you.
Thank you. Bye.